Hey, everybody. Thanks for joining us today. My name is Eric Norman. I'm a physical therapist. And shortly, Christian will be joining us, who's also a physical therapist. And so we're going to be talking about the elbow today, and specifically tennis elbow or lateral epicondylitis. Goes by some other names as well. I'm not saying them right now, mainly because I sometimes don't say them right. So we're just going to go with epicondylitis. Anyways, we're going to discuss a systematic review, break down different treatment styles, what seems to work, what doesn't, give some practical advice, and hopefully things you can put into action today if you're dealing with something like this type of elbow pain. Always reach out to us if you have any questions. If you want to have input on, hey, you should do this podcast, you should try this, or do this topic. We'd love to hear from you. Otherwise, hope you enjoy the podcast, and thanks again for listening. Have a good day. A decent chunk of individuals that get better within the next 3 years will have a relapse of low back pain. So it's like we know that it comes and goes. It's just for him right now in this more acute phase, he's weaning in and out, more like week to week, month to month versus year to year. So he ended up going and seeing a general practitioner who, didn't really do much for him, kind of told him like the same thing I told him. And then in terms of like coming from the back, it doesn't have any red flags. It doesn't seem too serious. And then he told him like if he wants, he can send him a referral to like a spine clinic. And so he came back this week and was like, is there anything else PT can do? And I'm like, well, like, first of all, sorry to hear that things have been waxing and weaning, but, yes, there is, right? I mean, we've been doing activity modification and basically a strength and conditioning home program for you. And it was thought to be going pretty well. Unfortunately, it took a wrong turn in the last week and a half. So I laid out stuff like, like we could always try like different pain modifying modalities. We could always do more like manual therapy. Like we haven't really done any of that yet. We can always modify the home exercises again or try and target different areas of like the lower extremities, the low back, trunk, etc. So I'm telling him all this. And I also told him like, if you want to, we could also maybe send you to like PM&R, like physical medicine, or we could, collaborate with the chiropractor that we have in clinic and, all these different things. And he was like, and like good for him because he was like, you know what? Like, I don't really like to go to chiropractors. He was like, I don't want injections or medication, and so like he basically was like, I don't want to do those other things because like, he's like, I just don't want to go to a chiropractor or I don't want to get any medications or injections. And so we'd had a really good conversation of like, all right, your back pain is safe. We don't need to like freak out and get you to like neurosurgery, but let's try some different things in PT to see if we can modify it. And just gave him a lot of education around what's going on. And I would like to think he left in a lot better spirits than when he came in. The funny thing is he is like, I don't think we should really do much today because he was like, I'm not in any pain today. He was like, I feel pretty good. So it's just, it was kind of funny about how it's like, God, it's getting worse, except for today, feeling really good. But sometimes that can be the nature of things. So anyways, quick, long story short, for individuals that have something like low back pain that is, can be quite frustrating with how it's been presenting, speak up, tell your PT or your healthcare provider what's going on, tell them, what you believe in and what you want to do for it, and let them try and give a plan around that that'll fit your needs best. Versus, sometimes we just tell patients, do this, do this, do this. And sometimes they don't want to do it, but they just kind of agree with us because it's like, oh, you're the healthcare provider. I'll do whatever you say. Like, yes, but also, be sure to like speak up and advocate for yourself.
Yeah, totally. I think that's a good summary of sort of like that clinical decision-making process that you have to go through with your patients, where we don't know of things that work every single time for every single patient. There's like no guarantee of success. You're doing all the things that you know that you should be doing for this person that has this style of pain, and it's not really working that great. at least not on the time scale that anyone wants it to work on. And so you just got to reinforce these are the things that really need to be done that we know work almost always with people to some degree. But like, what else can we do? How else can we change things? Can we bring in other people to offer maybe some different ways of explaining things to you, or just provide some of that short-term relief? And at the end of the day, the patient's just got to take all that information in and be like, okay, this is what I would like to do. And I love when you said that person didn't really want to do whatever it was that you offered. They're like, I'm feeling pretty good today. Let's not poke the bear.
Yeah. We could probably talk about patient stories all day. Unfortunately, we have an article to get to. So today, Christian and I are going to be discussing a systematic review on physical therapy treatment and lateral epicondylitis. Title of said. So Christian, I'm going to leave the floor open to you in terms of how you want to introduce this thing, or kind of start off with some initial points, and we can go from there.
Yeah, I think just starting off kind of like most introductions and papers go is they just start with like, hey, what is lateral epicondylitis? And how do we diagnose it and all that?
Yeah.
Just like, this is kind of what I tell patients. Lateral epicondylitis, or lateral epicondylalgia, which is mainly called now, is where the bone on the side of your elbow, where your forearm muscles attach, is really, really painful and really sore. It's also called tennis elbow. And tendinitis just means that the tendon or the bone where those tendons attach, which is the epicondyle, has some like true signs of inflammation that you could measure with like blood tests or whatever. Tendinopathy or epicondylalgia just means that the area hurts. That's a much more accurate way to say things, because oftentimes when people have pain in this area, there really is no large amount of inflammation that we can truly measure. So it's just more a matter of like semantics and accurate terms. And then how do we diagnose it? It's really straightforward. You press on the area if the bone really hurts. And if you press on that bone and that kind of pain that you get is the pain that you typically have, that's like the best thing that we can do. You can also do some stretching tests and some like muscle resistance tests. And if those also elicit that same kind of pain, that's probably what it is. And then also the last thing to say is we exclude other things. So like generally it's a very simple diagnosis to diagnose, but sometimes you can have weird stuff happening in your neck causing pain to refer down to the side of your elbow. And so we got to be paying attention to that. Or you have like a real joint issue in your elbow. Or there's arthritis, for example. So like we're looking for those things, but generally it's a pretty straightforward thing to diagnose.
I think that's a great introduction to it. Like you said, it's a pretty straightforward diagnosis. Once you see it a couple of times and then people present in the clinic, you get a feel for how it presents and how it doesn't present, right? So like you said, like sometimes you could have maybe some type of referral from the cervical spine or the neck. That can be doing weird things in the arm. And especially like if people have, a history, you said it's called tennis elbow. People play tennis a lot, or pickleball, or, any type of swinging sport with a racket, or anything that you're having to do where you're putting those forearm extensors on stress. I mean, yeah, the subjective usually lines up with the objective and the diagnostic criteria. But yeah, so no, awesome job introducing that. Another thing that I wanted to talk about quickly before we got into the meat and potatoes of it is, what the heck is a systematic review, right? So it's the way I like to think about it is just super straightforward. People who are very smart scour the research on this certain topic, and they pick from different research articles, and they get a whole bunch in a pile, and they have this criteria of, all right, what articles are going to be good enough to be reviewed and what articles aren't good enough, usually in terms of things like, how did they perform their research, right? Was there a lot of conflicting variables? Does these data sets seem to be, untrue due to false positives, false negatives, etc.? And then I think in this, they had like 400 some articles, and then they got down to like 19. So you could see they start with a lot, and then they throw a lot out, and then they systematically review these articles, and they talk about, with this one diagnosis, was this treatment shown to be effective or not? or was it partially effective or not really or very effective, etc. And they just kind of go through and then they make a list of here's things that work well with tennis elbow, here's things that work okay, and here's things that don't really work well at all. So that's a background on systematic reviews. And quite honestly, as physical therapists, we use these a lot when we try and decide what type of treatment we want to do for each diagnosis, because we want to make sure we're offering the best evidence-based treatment to individuals, and systematic reviews or meta-analyses are very good at giving us that confidence and this treatment is good based on the research.
Yeah, and they're just like really time efficient for us. We work 40 or so hours a week, oftentimes more because when you factor in documentation time and coming in early and staying late for people, whatever it is. And I don't have just like dozens of extra hours in a week to read every single individual research article. So I need faster ways to digest the material, and systematic reviews do that. And you can generally trust them, at least on their face, because they're using very rigorous criteria to determine how to best go about this study. But there are ones that are bad. If your whole review is made up of really crap studies, it's going to be a crap systematic review. And
Yeah.
usually the authors are pretty clear about saying that. But overall, we need to use these things. And I highly encourage patients to Google. You want to learn about tennis elbow? Google tennis elbow systematic review and see what pops up for you. That's a really good way to get introduced to any sort of material if you want to learn more about it. And they're pretty straightforward to read, honestly.
Let's get into it with kind of the first treatment that at least I've been noticing more since working with some of the local athletes here, which is shockwave therapy. I feel like I didn't really learn a whole lot about it in school. Like we didn't really discuss this modality a whole lot, but and maybe it's just the area that I'm in the Midwest, but I just feel like a lot of athletes I see, if they're going to chiropractors or, other kind of recovery gyms, like they're almost always talking about this shockwave therapy and like, oh, I got shockwave therapy on my ankle or on my knee or my hand, whatever it is. So let's discuss shockwave therapy in tennis elbow.
Yeah, I guess the first thing I'd say is it's honestly pretty promising. Last year, my clinic that I work at was looking at buying one of the units, and we had a presentation from the sales rep, which obviously take that for what it's worth, but they introduced me to the machine. We got to play around with it for a few months for free. And during that time, I was like, I'm going to read more about this because I didn't learn about it in school either. And I read a lot of, I read a lot of research articles on it for various parts of the body. And the research is pretty young. And so it's hard to say how effective it is. I think we need more time for the research to really give us more clear information there, but it's definitely not harmful. And the early stuff that's coming out seems to say that it could honestly be really helpful, especially for tendinopathies or epicondylitis, that kind of stuff. And so we are actually going to be buying a unit next year. We're going to get that thing. I'll be able to use one a bit more often, and of course keep reading research to see if I really should be using it and to what extent. But it's really the new hot thing in our industry, and it seems quite promising, or at the very least, it's definitely not harmful. And so I'm optimistic about its future.
The one thing that I saw, and this isn't a bad thing, it's just something that I noticed, is I feel like, at least in the research, the shockwave therapy, short term, it shows to be significantly beneficial overall, but also even when you compare it to some other types of therapies. But when you extrapolate it out to 1 year, it doesn't seem to have the same, there's no significant difference in terms of, at least in pain, when we're talking about conventional PT versus shockwave versus, other things. But again, that's not a bad thing, because if you're a tennis player and you're in season and you just need 6 weeks to get into the playoffs or whatever it is, and if you're able to get this modality done, and it gives you that 6 to 8 week pain relief to get to the end of the season, freaking awesome. And then, let's do it. Especially if the research is telling us it's giving us better outcomes than, other forms of modalities or conventional PT. So even if the long term isn't quite there, or at least like you said, the research is still young, so who knows? It might be there. We just need to do more research on it. I think even in the short term, it seems that it does have or can have a good place in terms of things like pain reduction.
Yeah, and maybe even long-term tendon regeneration. We're just not fully sure yet. It seems like it could, but they say that about a lot of different things that I'm
Yeah.
sure we'll get more into here as well. But yeah, I
Yep.
think what you
Yep.
brought up about like it's just like the practicality thing. I you and I think are very similar here where I want people to feel better in the short term, while
hmm
all the while I'm doing everything I can to get them better in the long term. And sometimes you have to make those decisions like, oh, this person is in season. They are probably not going to have the time or the energy to devote to a solid exercise plan or doing a bunch of heavy resisted wrist extensor exercises on that elbow right now might actually negatively affect their performance in the last 6 weeks of their tennis season, whatever it is. And so I want to do things just to calm that down, get them through the season, unless I feel like they're like really at risk of a major injury. But in this example, no. But I'm going to do that thing so they can get through their stuff. And then I'm going to let them know, like, hey, that's not going to cure you, but we'll do all the other things as soon as we can. That's just one of those decisions that I feel like you have to make on a patient by patient basis, and just let them know, this is what I think. This is the timeline for these things. What do you want to do?
Yep. Yep. Absolutely. Nope. Love it. Okay. So yeah, shockwave looking not too bad. The next one that I was reading through in the review was the use of orthoses or orthosis around that, we would call it more the distal forearm, right? So, I mean, when we talk about distal and proximal, where proximal is like more towards in the arm, it would be more towards the shoulder or the chest, whereas distal is going to be more towards the hand. So if we're looking at something like a splint or an orthotic being used in that kind of like that latter half forearm, wrist, and hand region. From what I read, showed some positive progress wearing it like 6 to 8 hours a day. In terms of, again, we're just identifying things like pain reduction. I want to say that it actually showed some reduction in like strength after wearing it. But again, 6 to 8 hours a day, your hand or your wrist is in one position. You're not using it like you normally do. Yeah, if you do that over 8 weeks or 6 weeks, whatever it is, probably going to have some reduction in strength a little bit. But it really showed that things are looking pretty good with it when you combine it with conventional PT with things like stretching, strengthening, etc. So orthotics and whatnot, that looks decent as well, especially with the combination of conventional PT. Now, my take on that is basically you have a spot that hurts, so then you just prevent it from moving. And then after 6 to 8 weeks, yeah, you didn't put any significant stress on it. You're basically just forcing activity modification with a splint. And it's like, yeah, of course, that's probably going to reduce any type of pain discomfort. It's like if it hurts to walk on your foot and you don't walk on the foot for 6 weeks, probably going to be doing all right. So I think that's where the benefit of the orthotics or the splinting of this condition comes into play. You're just forcing a lot of activity modification, basically.
That's exactly how I feel about it. I really have not prescribed that. I don't, maybe like once or twice.
I haven't either.
I do see
Yeah.
it from doctors every now and again, but here's the thing is like the times that I have done it or I've seen doctors do it, it's for the people that are like so miserable. They can't sleep, they can't get through their day. It's a really bad case and it just needs some time to settle down. And generally for any condition in your body, we really try to not recommend complete rest because the research on complete rest is really quite poor for almost every condition. But sometimes, again, very rarely, it has a place. And this is one of those times where, yeah, I might give someone a brace just to get through their night so they can actually sleep, because you have to sleep so you can heal. And then once things simmer down, we get into everything else we know that works really well.
Yep. 100%. 100%.
Well, going off of the
Yeah.
bracing, that kind of leads me to my thoughts on taping and also your
Yeah.
thoughts.
Yeah.
Because that
Yeah.
was talked quite a bit about, or it talked a lot about in this article. So I know I have lots of thoughts on taping, but I wanted to start with you. Did you have any?
Yeah. So they talk about what was the exact thing they use? Biomechanical bandage technique with muscle energy and subsequent whatever.
Yeah,
So
whatever.
my thing on this, they talk about taping on the skin influencing structures below or deep into the skin, specifically the muscle, and they even talk about the fascia a little bit. Now, I don't know if we've had this conversation yet, Christian, because this is kind of my new shtick that I'm on when it comes to things like taping. When they say it's going to affect the structures below through things like fascia and muscle. When I was taking the course with our well, I can't say our friend, but our guy, Greg Lehman,
Our idol.
our idol. Yeah, yeah. Maybe one day he'll be a friend, but for now, just our idol. He was discussing how one of his colleagues or friends did some research and showed that, that fascia is a frictionless environment. And so if you're trying to do this with tape to like pull on the muscle, well, if it's frictionless and then that tape isn't going to be able to affect the fascia or the muscle in theory because it's a frictionless environment. You're not going to be able to, pull or manipulate that muscle in any way because it's kind of under this protective barrier of that. I have a hard time getting into based on that research that he presented. I have a harder time kind of buying into this idea of bandage technique for muscle energy and all this other stuff. Just because I think from like a foundational level, I don't think it's there. But with that being said, when you look at some of these research studies, individuals evaluated with usage of like KT tape versus placebo bandages, both having a conventional PT program alongside with it, actually showed better improvement with the different outcome measures of the research study if using KT tape versus placebo bandages. So, I mean, there's results there to say that it is showing benefit, but again, I just have a hard time with this just from more of that foundational level, I guess.
Yeah, I think that's a very important distinction to make is that are people getting better when they use tape? Yes. Is the reason that they're getting better very likely going to be blood flow related, fascia adhesion, friction, biomechanic optimization? Almost assuredly not, because it's just like the
Mm-hmm.
concept is ridiculous.
Yeah.
Maybe that's a hot take, but like I'm sure if you measured it like with very crazy ways, and there could be even some research on this, you might see some changes perhaps, but it's so minimal if there is anything that it's probably not really that important. But
Yeah.
going off of what you said about that study, I did see those studies cited in the systematic review. The problem is I don't know exactly how they made that study. For all I know, the KT tape versus the sham tape, they might have like used a really cool tape, like true KT tape, which like looks good, has cool
Yeah.
colors,
Yeah.
it's
Right.
got a good feel to it, and like you might just use some like awful branded tape that just looks lame. Like all these little factors and like the way you do it. Like maybe you're putting on KT tape with the different techniques and the layering and the like
Yep.
pulling on stretch or all this stuff. All these different factors play a major role in the patient's expectation of how it's going to work. And that's the big thing about taping is that by and large, it seems to be working with the placebo effect. And I'm not here to say that that's not real, that's not useful. 100% I support the use of the placebo effect if it's going to be to your benefit. Even if you know it's placebo and you can still get better from it, 100% fine. What I take issue with and what I strongly discourage from happening is when clinicians, or really anyone who applies tape from like a professional standpoint to a client, if they're saying that it's working for these reasons, it's going to decrease your inflammation, all this stuff, they're probably lying to you to get you to continue to use their service, or worse, in my view, they're very ignorant of the research around this stuff and how it actually works. And that's kind of dangerous, like I don't like that. So, and it's just like harmful to the trust of our profession. It's harmful for the patient because they might have all these expectations now around how this tape is going to work. And then when
Mm-hmm.
that's not fulfilled, when that doesn't actually happen, they're just kind of lost. Like, oh, you said it's going to work in this way. How come it's not working for me? They're putting trust in this thing that's not really supposed to be that trustworthy. And that's just
Yep.
inherently harmful.
Yep. Yeah. I agree with that. No, I think you kind of hit the nail on the head there because you're right. Like I see other PTs in our clinic that from time to time will use something like KT tape and, their patients get better with it. And, it's like, if you're getting better with it, it's a pretty cheap thing. It's, something that you can learn how to do and do on your own. It's like, if it's benefiting you, and then do it, right? And especially it's not causing any harm. So, unless it's like giving you terrible skin irritation or something.
Which does happen. I've seen that.
Which, yeah, yeah. So yeah, I think we're both in agreement on the taping part of it as to it does show benefit, but where that benefit's coming from can be heavily argued, I think, or discussed. And I think if you listen to the last 5 minutes, people clearly know our viewpoint or standpoint on why it's having benefit.
Well, it's also just kind of generally for any intervention. Okay, so it shows that it makes your pain better in the first 2 weeks or the first month. Okay, cool. Lateral epicondylitis, tennis elbow, whatever, you're not talking this diagnosis getting better in a matter of weeks. This is a 3 to 12 month process for almost everyone that has this, sometimes even longer. So like when you're telling me that this treatment, whatever it might be, works really well, better than something else in the first 2 weeks to a month, I literally don't care. It does not matter to me because that's not gonna be the patient's lived reality. They're gonna have this thing for many months, kind of like you said earlier, waxing and waning. You're gonna have periods of regression, and
Yep.
you just gotta be thinking about it on that long-term scale as well, because that's largely where the real benefit's gonna lie.
Yeah. Yep. Absolutely. I totally agree with you. When you take in the natural course, the natural history of this type of diagnosis and, usually how we see them get better at a slower period. Yeah. In the first couple of weeks, it's like, I mean, I guess if your pain is 8, 9 out of 10, and we can do some of these different taping or different modality techniques to bring your pain down to like a 6 out of 10 so that your quality of life is better. And then, yeah, I totally see that, right? But if we're talking about like, I'm going to make your pain, I'm going to make your diagnosis better or get you to discharge by utilizing only tape or only, a splint or only this, whatever it is, right? Outside of what we're probably going to talk about in a little bit here, exercise and manual therapy, etc. Things that we know are kind of the big hitters with it. And then that's when it's like, all right, now we're having a little bit of an issue here because we're using things that are only showing improvement in the short term when we know this is a more long-term rehab process just based on the history or the prognosis of this diagnosis.
Yeah, and I think just this whole taping discussion tees us up nicely for the manual therapy discussion. So in my view, manual therapy is still more of a short-term pain relief kind of thing, but there's a lot more promising evidence for manual therapy techniques across the board for like loads of conditions in your body, but definitely for lateral epicondylitis. And when we say manual therapy, just for the listener, that means a lot of things. So that means massage. That means like general like effleurage type massage, deep tissue massage, scraping techniques with tools. That means like joint mobilizations, like Mulligan type techniques, Kaltenborn techniques. It means chiropractic adjustments of your elbow. It also means dry needling. All these different things are manual therapy. And
Yeah.
there's like thousands of studies on this stuff for every single type of manual therapy that you can do. But by and large, if you lump them all together, in a not so systematic review that I'm talking about right now, they work pretty well in the short term. And you just got to figure out which one works well for you based on your preferences and like what your therapist, I guess, knows how to do.
And there was, I think, one study in here that with manual therapy discussed like improvements or significant benefit being shown like up to 1 year. But again, that was one research study in a field of thousands of research studies. So I take that at what it is. there could maybe be some promise in having more long term with it, but I agree. For the most part, it's just short term. And I kind of come from manual therapy in terms of the pain modifying aspect. I don't, and maybe we disagree on this, and it's okay to disagree. We can disagree on things. But I think I don't come into manual therapy thinking as much of mobility improvement based on the sole fact of manipulating the joint surfaces and the joint capsule, etc. I think that was it Chad Cook from Duke University. This was a while ago. Orthopedic professor at Duke University put out an article about basically why we should still do manual therapy. And it was basically all around like pain modifying aspects with like the peripheral and central nervous system, and how, if you can modify the pain, and then likely that's going to be able to allow people to move more, move better. And so that's kind of where I come at it, is utilizing manual therapy to modify pain in the short term versus like manipulating the joint surface, joint capsule, etc. to gain you X amount more degrees of motion or whatnot. Not to say that isn't there, but for where I'm at with the research I've read, I just think that's where I come from with manual therapy. So yes, more the short-term pain modifying aspect, especially in this case of the tennis elbow.
Right. I saw Chad Cook and a couple other prominent voices in manual therapy speak this past February at the combined sections meeting for the American Physical Therapy Association. It was an awesome 2-hour lecture. He did a phenomenal job, and he basically said exactly what you're saying, where years ago, decades ago, even some people now who are kind of charlatans will say like, yeah, I'm doing manual therapy to change your structure or whatever other words you want to use. But really, that's not what we're doing anymore. It's not what the research says. It's more along the lines of, it makes you feel better. It messes with your pain processing in a good way, usually. And we're going to use that to great benefit for you. But we're making sure that you're aware that we're doing that. We're not giving you false hope. We're not lying to you about how this is going to work. I literally tell patients like, hey, I'm going to set you up with these exercises. Here's how you're going to do them, which we'll talk about next, I'm sure. But since you're here, do you want me to do some deep tissue massage? Want me to do some deep tissue massage? It'll probably make you feel better for the next handful of days. And almost always are like, hell yeah, please, thank you. I'm like, great. You were just an informed consumer. I told you it's not going to cure you. You said you want me to do it. The exercise component is going to take me 10 minutes to show you anyways. So like, let's just do this stuff while you're here. Let's do it all.
Right.
And so that's how I tend to have it play out.
Yep. Right on, man. Yeah, I agree. So we do agree on it. Look at that. Hey, we don't have to disagree yet. All right. So looking at the time here, I want to make sure we give enough time, give therapeutic exercise its due. But just real quickly, another thing that seemed to be more short term in this systematic review were things like injections. Individuals getting some type of injection, like a steroid injection or like a PRP, seem to give really good benefit in the short term. But when you look at individuals, when you extrapolate that out to like 3, 6, 12 months, it didn't show significant difference or change versus just like conventional PT. So again, if your pain is a 9 out of 10 all the time, you can't live with it, and you want something like an injection to just bring that down in the short term, perfect. I'm all for that. Now, to say I don't need physical therapy because I'm going to get an injection that's going to cure it, I wouldn't go that far, but I think it definitely has its place.
Yeah, I think everything you said is great. The only thing I'll add to that is, like you, I do work with a lot of sports medicine physicians. They're really just like down-to-earth, practical people. They're like, look, Christian, we know physical therapy and just like generally exercise is probably their best bet for this kind of thing, but we give injections all the time and don't refer to you. And it's not like we don't like you guys. Like, we know you guys do good work, but there are other real world things that you have to consider that we hear from people every single day. One, physical therapy is too expensive for them. They can't afford it. So that they're going to do that one-off injection for now and, roll the dice. Hopefully it makes them feel a bit better alongside natural history taking care of them. Or maybe the patient just doesn't want to do PT because they just don't care about it and they want that quick fix. They're just hoping that's going to work out for them. Fine. Maybe the patient has had bad PT experiences in the past and they're just like, you know what, I've been to PT for this or for other stuff before. Didn't like it, don't want to do it, not interested, give me the injection, please. And then also, they just don't have time. Maybe they have 2 jobs, maybe they have young kids, maybe they commute really far. Like for me, where I live, it's not uncommon to have people commute to Boston several days a week, which is a 2-hour drive. they're not going to have time to come to physical therapy during normal, like 9 to 5 business hours. So these are real world considerations for why someone might not do physical therapy and might just do the injection route. And, is that ideal? No, but that's life.
Yep. Right. Yep. Yeah. And you got to roll with it. And what I, what I really enjoy, at least sometimes, which I think some people, it's like, why are you coming to PT if you only want to do one visit? But sometimes I think it's even a good idea to just like, if the patient, again, they live far away, if it's something with their lifestyle, they just can't, they're too busy, they can't do it, or they don't have the money to pay for several visits, whatever it is. Sometimes even just like doing one visit, coming in, what's going on, so that we can educate, we can discuss your different plans of action that we could do, and just get you a good comprehensive home program and say, all right, all we had time for or all we wanted to do is just one visit. Thanks for coming in. Here's a nice comprehensive home program, educated you on what's going on. If you have any questions, give a call or send a message or something like that. I think sometimes that's a really good way to go as well, and just allowing the patient to be independent with their own care after one session.
Yep, 100%. I think that's a really good segue into what do we do regarding exercise. So when it comes to thinking about exercise in the treatment for lateral epicondylitis, you're really trying to accomplish one of two things, or maybe even both. One is you could be hurting because you truly are weaker in that tendon and you're asking it to do more than it can comfortably handle, and you need to build up that strength in order to really get better. Or the other one is that your tendon's been overworked, or it's just kind of sensitive, it's irritable for whatever reason, and now you have to use movements and exercise to teach that tendon how to like those kinds of things again. So we use exercises for largely those two main concepts. I'm not going to get into like all the histology and all that kind of stuff, like what we're actually doing with exercise on a structural level, but that's generally why we do it. Now, what does that look like for most people that have this diagnosis? There are several approaches, but the one that really is the most promising in the research, but also I think the most accessible to most people's lives, is going to be the classic heavy, slow resistance approach, which is where you, over time, you lift heavier and heavier weights with a couple exercises. You're going to be doing these exercises about 3 times a week. That's a really good starting point. How many exercises should you do? You should probably do like 2 to 3 exercises on each day. Okay? They can all be the same ones too. How much should you do? Probably like 3 sets of 12 to 15, 10 to 15 is a great starting point. But then like how should that progress over time? Going back to the heavy part of the heavy slow resistance is you want to keep increasing the weight of these exercises over time. And a good way to do that, or an easy way to do that, is you just decrease the reps you do over time. So like a thing I'll say to patients is, this is going to play out pretty straightforward. The first couple of weeks, I want you to do 3 sets of 12 to 15. Then I want you to do 3 sets of 10 to 12, and then 3 sets of 8 to 10, until we get down to like 3 sets of 5 to 6. I might even add a 4th set in there somewhere if I need to. And every single time you take a step down in that rep range, I want you to keep adding weight. And the reason for that is, it seems like lifting heavier weights tends to work a lot better because the tendon cells in your tendons respond to maximal tension. How do you make maximal tension? It's not from doing like 3-pound wrist curls for sets of 20 to 30. It's adding heavy weight, going through a maximal stretch, and feeling the tension in that sore part of your elbow. Like you actually want to feel something happening there. So that's generally the kind of guidance I'll give to patients. And what's great about that is it's super simple to do yourself. So like you said, you might see people for one visit and just give them this sort of the synopsis, but like I'll do the same thing. I'll be like, hey, here's your first batch of exercise guidance. I want to see you in a month. You come back in 1 month after you've done this month of work. I'll change this stuff for you based on how you're doing. And the reason I'm comfortable seeing people so infrequently is because this process takes a super long time. Like I said earlier, it's like a 3 to 12 month journey for most people. I'm not going to cure you in a month, seeing you 3 times a week. It's just not going to happen. And so you can take the liberty assuming you're disciplined and motivated enough to do this stuff on your own with just like some very straightforward guidance for me.
No, I think that's a really good introduction and really just a good overview of therapeutic exercise and why we want to do the heavier lifting or the heavier loading. And also another thing I just wanted to add was something I like to think about too when it comes to tendons and loading and tendon rehab also is just general time under tension as well, So if you're starting out with a good 3 sets of, 10 to 15, 12 to 15, if you're doing lighter weight, you're still getting a lot of good time under tension to put stress into that area to activate and do things that we want to do that we know is going to, improve that tendon back to where we want it to be. One thing that I just want to touch on is a quick little kind of teaching moment for individuals out there that might not be familiar with some different types of contractions in muscles. So believe it or not, our muscles contract in different ways, not just one way. And when they talk in this research article and really any kind of tendon rehab overall, we try to apply what's called an eccentric contraction. Eccentric loading or contraction allows us to load that muscle and tendon more than the other two types of contractions. So this contraction is actually a contraction of, it's a lengthening process of the muscle fibers. So this is like your muscle fibers at rest and tendon, collagen, etc. at rest. As you lengthen those fibers and connections, we're loading it, or it's a controlled contraction kind of apart. That's that eccentric contraction, that eccentric loading. The other one is going to be concentric. That's what we think about the most, right? As you activate a muscle, the fibers come closer together and that the muscle shortens and it brings food from your hand to your mouth, right? That's a great way to think of concentric contraction. And then the last one is isometric, which just means when you contract it, the fibers just stay put and there's no change in the fiber length. So you can do any 3 of these for some type of tendon rehab and you're probably going to see improvement. But we just know that doing eccentric loading allows us to load things more. And like you said, the more we can load things, we see the more benefit we get from it.
Yeah, I think you breaking down those muscle contractions is really good. Like a simple example, I guess, is the pull up. When you pull up, that's the concentric. If you were to pause at the top and just hold your body up there, that's the isometric. And then when you lower slowly, that's the eccentric. In the research, the 2 types of contractions that seem to work best, like you said, eccentric number 1 is the best for almost every circumstance. But there is a lot of good research on doing more isometrics as well, where you're just holding muscle contractions, and it largely seems to have the most benefit when people have the most pain. So it's just it's not super stressful on the muscle tendon structure itself, but that contraction you're doing seems to help your pain the most, or at least quite a bit when you can't quite handle the eccentric contractions. So I do give those to people who are having a hard time. And it's kind of like going back to the very beginning of this podcast when you said for your client with that low back pain flare up, you gave them some more core stability exercises. By and large, those are isometric contractions. And that stuff, when you contract all the muscles right around that sore part of your back, that can tend to feel pretty good. And that's why we give you those.
I think the last thing I just want to talk about with the exercise component is that in the end of the article, they kind of conclude with, eccentric isometric therapeutic exercise program around this type of diagnosis is like, that's what we want. That is top notch. That's where we want to be. That mixed with some manual therapy, those are the things that are showing like kind of the best outcomes. And then, there's some other things like shockwave and some other modalities that show some other, short-term benefit promise. But all in all, it's kind of holding true to what we like to do every day, which is prescribe therapeutic exercise. Quick kind of conclusion for me around this article and for individuals watching this. If you have pretty mild tendon pain, assuming you have something like tennis elbow, load it, load it, load it. Right? That's kind of what I would say. It's a 10,000 foot overview picture. Load that sucker. Now, if you have tennis elbow and that thing hurts like a son of a gun and you can barely pick up a pencil or something, and then, you know what? Maybe something like an injection, maybe something like shockwave or, taping. I don't know. Maybe something in this short term to get your pain to come down is going to be a good thing. And like you mentioned, doing more, maybe a little bit less intense isometric contractions for those individuals. So yeah, so it's pretty straightforward. If you're pretty mild pain, load it. If you're more on the severe side of pain, let's try and find a short-term pain modifying intervention, along with starting with some more isometric, lighter therapeutic exercise.
Yeah, and I guess the last thing I'd say is if your therapist that you're working with right now is trying to get you to come in 3 times a week for like 6 weeks for this diagnosis, maybe just ask them if you really need all that, because you probably don't.
Nope, I'm with you. I'm with you. All right, awesome. Well, I think that was quite the breakdown of the article, all in all. If you have any questions about tendon rehab in general, or if you're dealing with tennis elbow at this time, feel free to reach out and hopefully we can, help out with something more remote. Obviously, if you have any questions about programming or anything like that, please reach out. Otherwise, thanks so much for listening today, and we'll be back next week with, I don't know, we'll have to decide yet again what we're going to talk about, but I'm sure it's going to be something good.